Good afternoon. Welcome to the 10th seminar of the seminar series Bridges, organized by the Hellenic Initiative Against Alzheimer's Disease. It is a honor for Bridges today to host two sleep experts who will talk about the relationship between sleep duration and memory function. The exact topic of the seminar is long sleep versus short sleep, what is good for our memory. The first speaker is Professor Vgotzas, who is Professor of Psychiatry at the University of Crete and at the PennState College of Medicine, and he is the Scientific Director of the Mobile Mental Unit of the University Hospital of Heraklion in Crete. Professor Vgotzas, the floor is yours.
Thank you, Panos, and thank you for the invitation. As we said, the talk will be divided between me and Maria. And Maria, I think, has done a lot of work on this issue. I'll make the introduction. So, Maria, can I have the next slide? Thank you. Came from when I was giving a talk, I think here in Heraklion, from a non-physician, from a simple man, who said, "Hey, doctor, you're always saying sleep is good. Then why if you sleep more is bad?" So I was telling him, both short and long is not good for you. And I said, what I read in the, lay press is sleep is good. What are you telling us? So a good friend of mine, pointed to me something that Hippocrates has said about, 2,500 years ago. I will bring the translation of that. It says, τόσο ύπνος όσο και αγρίπια, αν ξεπερνούν το μέτρο, σημαίνουν ασθένεια. Με άλλα λόγια, if you sleep more, if you're awake a lot, and if this is beyond the happy medium, then this means illness. Let's find out whether we have made any progress after 2,500 years, and whether we can move a little bit forward the field in understanding why both of these situations that appear to be on the opposite extremes, they end up being bad. Here is the outline, just for the sake of time. I mean, the usual stuff for how, just a second, Maria. How sleep changes with age, sleep disorders in elderly, and then we'll move quickly, to the issue of sleep duration, sleep quality, and how this affecting cognition. And we'll use lots of data from the Cretan aging cohort, but also some data from PennState, the Sleep Research and Treatment Center. Where can we move to? Here is just, I always present this slide. This is in honor, now it's in memory of Anthony Cales, who passed away just a month ago in Florida. He was my professor and mentor, and I proudly carry, the Anthony Cales Endowed Chair of Sleep Disorders Medicine at Penn State. As you may know, he was a pioneer. You can find his biography in Sleep Advances that just came out about a month ago. As you can see there, he's upbringing in Detroit, and his Greek background. His family came from what we call Southern Albania, Northern Epirus, and he was a pioneer in sleep. In fact, he was the first one to establish the first sleep disorders clinic at UCLA in 1963. And as some of you may know, along with Alan Reshaffen, now he's also passed. From the University of Chicago, they established the first sleep scoring criteria. This is from a paper exactly 50 years ago from New England Journal of Medicine. And you can see in the back, the old sleep machines, those that you have been only lived in the digital world, that were the things with green ink, and you will get, all green, if you have a white coat and so forth. And Tony, among the other things, published studies on how aging affects your sleep. Basically, as you get older, slow wave is less and less. Even REM, there is a little bit of decrease, but primarily duration and sleep efficiency goes down. And superficial sleep stage 1 is decreased. Maria, can we go ahead? Okay, now this is this was given to me by Maria, who has really worked hard on this issue of aging, and that our population gets older in Greece. Greece is the 6th highest in the world, with people more than 60. And as we get older, many things happen, and one of them is dementia. Now, not all of us will get demented, but for sure, the older we become, the higher the chances of having cognitive problems and dementia. Next slide, Maria. Okay, next slide. And since, we don't have a cure, we don't have really a treatment. In fact, I have to say, if there are here neurologists, actually, I was talking to my daughter, who's a neurologist in Boston, Brigham. I was telling her, I never prescribe this so-called, memory enhancers. Hey, Dad, I said, don't be that rich, It may help a little bit. Anyway, there is the news medication. I think as Kostas Liketsos has told us his opinion, and I go by that. So, can we do anything, to prevent, to protect these people, and as early as possible? So, BMI, sleep, physical activity, diet, isolation, loneliness, social contacts. WHO just came out that loneliness is a very bad thing. We know that with the mobile unit that Panos mentioned, where we're taking care primarily of elderly people in the semi-rural and rural areas of Heraklion, loneliness is a big issue even for Greece, despite, the common perception that in Greece, we're just a nice family, a nice village. That's not correct. After 11 years visiting all these health centers and villages. Let's go further. So I'm going to focus on the short sleep and how is this related to cognition. And I think Maria is going to focus on the long sleep. The literature is there that insomnia, yes, can affect, cognitive performance. But next one. But when it comes, in terms of sleep duration, and I'm talking about sleep duration is subjective or objective, the results are mixed. There are a few studies that they have identified the U-shape and association, meaning the two extremes, are not good for you. In other words, short and long sleep are associated with problems. But what is the exact association? There is an association. The epidemiological studies are telling us there is an association. But what is the direction of the association? That's the important thing. Let's go next one. So here I'm going to present the findings from the Cretan aging cohort. Go ahead, Maria. And here this study, the beginnings of this study was back in, it's almost 10 years, 2013, 14, 15. It was a good moment for the University of Crete. I have just been a few years here, and my good friend Dimitris Boubas invited me to lead that project that included the Department of Psychiatry, Neurology with Andreas Plaidakis, Dimitris, who is now in Athens, and Christos Leonis, who is now also an emeritus professor like me. So our 4 departments, work together. Let's go ahead. And from a reference population, 40,000, primarily rural, semi-rural areas, just only a few subjects from the city of Heraklion. And they were visiting, the health centers primarily, to get their prescriptions filled. And through different filters, finally, we evaluated about 3,200 people with a general questionnaire. This was done usually by a nurse or a student and so forth. And the screening test was the MMSE. And then a group of about 500, we invited them to establish a diagnosis, either that was depression, anxiety, or dementia, or MCI, based on a full neuropsychological evaluation done by neurologists like Yannis Zaganas, Psychiatry like Maria Basta, and others. And as a neuropsychologist, Akis Simos, who is really one of the best ones we have, not only in Crete, but I think in the country. And this was the phase 2 and the phase 3 that this is the place that Maria is going to talk more, and she's the PI of that. Let's go further. Okay. The money was not that much, as you may understand, so we cannot afford, a PSG. A PSG is expensive. So we need to have something. This is actigraphy. Actigraphy is not the best instrument, to measure sleep, because it measures basically motion, motility. Yeah? Accelerometer, as the British people call it, was reviewed recently, some data from the UK Biobank, and they are of interest to us. And so, if you are motionless, this means sleep. If you move around, does not mean sleep. You understand that the possibility there for inaccuracy and artifact is there. So this is what we have. This is what I'm going to present in terms, of objective sleep. Now, Maria, in the third phase of that, she was capable one, of obtaining money for a smaller group, obtaining a PSG. Oh, don't you know where is Crete? If you do not know where is Crete, then you are in trouble. Please leave the session. We are really insulted. All right. And now this is the first paper with Maria, the first author. The insomnia symptoms were really very prevalent, very high, like 60%, unusually high. And we looked on sort of different ways that they remain high. Again, this is an older population, but it is on the higher side. Could it be an instrument? Could be. Anyway, so we found that insomnia is very prevalent, and insomnia is associated also with cognitive impairment. And that was in the large group of the 3,000 and more, using as an instrument MMSE. Let's go further. Now, how did we come up with this idea of short sleep and long sleep? Our group from Pennsylvania, my group from Pennsylvania, had a long-term interest in insomnia, even from Cale's Times. After 40 years, the field has concluded that for insomnia, we do not need a sleep lab, we do not need objective measures. All that you need is a good clinical evaluation. You can do it on your office. That was the gospel. That was the Evangelion of Tony Cales. That was at the beginning of my career. I was a little bit disappointed because I said, look, that was what also kept me in psychiatry. Here we have an instrument, that can monitor sleep minute by minute. And okay, for sleep apnea is good, but for insomnia, nothing. And so with a good help, let's move further, Maria. Let's move further. Let's move, and with the good help of good colleague and friend, George Crusos, a well-known, international figure on the stress system and professor in Athens and now still active in research. I said, George, let's find out, what's the biology of these two very prevalent disorders of sleep. Sleep apnea, we've published a lot on sleep apnea, inflammation, insulin resistance, and the like, metabolic syndrome, and insomnia. Everyone knows that no one wakes up one morning, having insomnia. Everyone knows, that something happens. You may be genetically vulnerable to light sleep, but usually stress is there, so we start the stress system. This goes from a 24-hour. The first study was in 1998. The second one was in 2001. This is from a study where we're collecting 24-hour blood every half an hour, 48 samples. Maria has helped in that, and she remembers these hard days of collecting, and we're collecting and we're measuring both ACTH and cortisol and IL-6 and the like. And go back, Maria, just one slide. So we said, with George, if your cortisol is elevated, not because you have the stress of giving a talk, or pass an exam, lost a friend, financial disaster, and so forth, but because you don't sleep well, then that's not a good thing. The other thing we observed there was that those that they had high cortisol were those with short sleep duration. In fact, in an 8-hour recording, it was only those that they were sleeping for less than 6 hours that they were secreting higher ACTH and cortisol. Therefore, we said chronic hypersecretion of cortisol, not good for you. Also, we have the same data I'm not presenting now about the adrenergic system. So the first study, that has become quite popular and widely cited in 2009, using the large PennState cohort of 1,750, Dr. Bixler's cohort, both men and women from the general population, random sample. And here we found increased risk for hypertension, both prevalent and incident, increased risk for diabetes, neuropsychological impairment, increased mortality in men, increased risk for schizophrenia, and the like. So we concluded, based on this, based on physiological data, clinical data, and epidemiological data, that insomnia with short sleep duration is not the same thing as insomnia with the normal sleep duration, and it's the most severe biological phenotype. Let's move forward, Maria. And here I'm presenting the first study that we did with our psychologist, PhD psychologist, Dr. Fernandez Mendoza from Spain, but now well established in the United States in our lab. It was published in Sleep 2010, and these old times, we brought these people, these 1,700 in the lab, and they have an extensive neuropsychological testing of 2.5 hours. So it was not just an MMC and so forth. So we were only 5 minutes. Oh my goodness, I'll move. I thought I just started, Panos. Okay. All right. Then that was the first study. Let's move, Maria. And then a more recent study with first author Dr. Mendoza is that there is an interaction between insomnia with observed sleep duration and cardiometabolic factors such as hyperglycemia or hypertension in terms of brain insult, like strokes and the like. And what he found is, we know diabetes and hyperglycemia and hypertension are risk factors, but when they interact, then the odds ratio become much higher. Let's go further. And here we come back to the Cretan data, and in 2019, we published a paper that I consider very important. Maria is the first author and put a lot of effort in that we found, that cortisol levels are increased in patients with mild cognitive impairment, and this is not something unanimously accepted. And we found also that the highest levels was in those suffering from insomnia with short sleep duration. Next slide, Maria. You can see that figure. These are all published data. You can see, there is a dose response effect. The non-insomnia guys, the controls have the lowest levels, the highest levels is in this group ISS. That means insomnia, short sleep duration. Thank you. Let's move. Because I can hear, Panos whipping, on my back. And this is here based on the neuropsychological data and analysis that was done by Desmond and Dipa, PhD psychologist from Switzerland, working together with Dr. Simons. And this is where we found, this association. Let's move. Now I'm going to present some unpublished data presented just in a conference this year, and these are the new things. From the cohort that Maria is in charge of that. And this is longitudinal data. And you can see here the title of this poster presented in the meeting in May 2023. Let's move, Maria. Okay, I have shown you that. So we're talking about the blue one at the end. This is the LEDEC. Let's go, Maria. Here you see the Thalis study. We have 4 departments. LEDEC study, just one department and one person from pulmonary medicine. We really, we could not keep, this good large collaboration. And here Maria shows you in this logarithm how from 3,000 ended up examining those that they have no cognitive impairment with those that they had MCI. Let's move forward. And we did an analysis where we compared, let's move forward, Maria, just for the sake of time. Okay, see, you see at the initial recruitment, we talked about that. We ended up in those that we brought in the clinic where they have a full neurologic, psychiatric, neurological evaluation. This was done by 2013-14. And some of them, as we said, we had actigraphy. And then 8 years later, and this is the grant that Maria is in charge, we brought them back to see what has happened to them. So you can see baseline, 57 of them, no cognitive impairment, 53 of them, they have mild cognitive impairment. So what happened, as you can see, even some of them that they were not cognitively impaired, they ended up having MCI, 6 of them dementia, and as expected, those that had MCI, a much higher number, ended up with dementia and MCI. So let's go further. What we found, what was predictor, because here we're talking about longitudinal study, okay? Just keep that in mind. Low sleep efficiency. You know what low sleep efficiency is? Sleep time, and this is not subjective, it's objective, with actigraphy, of course, versus time recorded, okay? So a 0.8, 80% and 0.8, below that theoretically considered that the sleep is not of that good quality, and we found there was a significant association with predicting which either from the non-cognitive impaired or the MCI will end up with dementia, with impairment, like they moved one step further towards deterioration and insomnia symptoms. Maria, let's move further. And this is another study that was done again by one of the students of Akisimos, Eleni Skouti, and using now more extensive neuropsychological testing, they found this long-term association between objective, you can see it here, between sleep efficiency, wake time after sleep onset, and memory indices. Here from diagnosis, we're moving on to using data from neuropsychological testing. Let's move forward. Okay, and why this is important from the therapeutic standpoint, and I will take only 2 minutes, Panos, and I'll be done. And I think I'm really on time because we started late. Because of you, we started late. I was ready at 5 o'clock. And why it's important now for you that maybe you do not have a background in psychiatry, you're a neuroscientist, neurologist, whatever it is. At this point, when I started sleep medicine, it was psychodynamic therapy, doesn't work now, plus medication. Then it was primarily medication. But now it's CBT, cognitive behavioral treatment insomnia, which means the American College of Physicians, as well as the British College of Physicians, etc., have said, if you have an insomnia, don't give medication. Start on CBT. And only then if it fails. That's the rule. But we have 10% of the population have severe insomnia. I mean, we need thousands of therapists. So it's a matter of resources. Then a guy who has developed, Jack Endinger, along with Charles Morin, Jack Endinger from US and Charles Morin from Canada, they developed the so-called CBTI. It's about 6 sessions. And they said, okay, these Vgontzas, say that there is that difference, and we're hypothesizing and proposing that social liberation with a high cortisol and so forth responds better to medication, while the other one responds better to the psychological treatment with CBT. And he said, I was going to prove Alex wrong, but Alex won and he was right. So he reanalyzed data that he has published in JAMA in 2000. And this you can see from 2017. Let's move forward. And then we came with a pilot study where we compare trazodone, which is the most commonly used, non-FDA approved, not being promoted by pharmaceutical industry, but commonly used by every physician, PCPs, and so forth, psychiatrists. And we compared to cognitive behavioral therapy, and we found that in insomnia with short sleep duration, this medication has a better response, both in terms of sleep duration and both in terms of lowering the cortisol levels. Let's move forward. And this was another study that from reanalysis of the same data using fast Fourier quantitative EEG analysis. And we saw with one of my students who is now in China, Yun Li, that trazodone compared to CBT was associated, with increase in slow frequency, decrease in high frequency. And let's move forward. And I think I'll be done almost in a second. And here it comes from a study, I think it was a retrospective study from neurologists at UCLA, where they showed that the use of trazodone compared to a group that was not using trazodone in people with mild cognitive impairment, that there was a slowness in deterioration in terms of their cognitive status in a period of 2.5 years. Now, I want to say, that was back in 2000s, I was member in a group and this was group, gathered by Sanofi, and they were trying to promote as a hypnotic medication that will increase slow wave sleep. So just not to make, premature conclusions, and, it failed. It failed, and the whole division of Sanofi that was promoting, I remember one of them was ritanserin. It was an H1, H2 receptor. Unfortunately, it didn't work for insomnia. Let's go further. I think the summary is here. Insomnia objective sleep duration is associated with high stress levels, though. In other words, with now not only prevalent data, but longitudinal data, it appears that short sleep duration with increased cortisol, it leads to cognitive decline and furthermore to dementia. Now, you may have a question, and I will answer it as quickly as possible. In dementia, we know that cortisol levels are even higher, but this is not because of stress. In MCI, we believe, and we have data on that, cortisol is elevated because of stress, anxiety, and so forth. In dementia, there is no such a thing. I think it's a dysregulation of the HP axis that, as you know, starts from CRH, ACTH, and cortisol in the brain. And here, I think I'm done. And the baton is to Maria.
Okay, thank you.
Many thanks, Professor Vgotzas, for this nice, very interesting talk.
I see a question, but we should leave it at the end, Panos.
At the end, yes, it will be better. Yeah. The second speaker is Maria Basta, who is Associate Professor of Psychiatry at the University of Crete and Director of the Psychiatry and Child and Adolescent Psychiatry Departments of the University Hospital of Heraklion in Crete. Maria, the floor is yours.
Okay, thank you, Panos. Thank you, Dr. Vgontzas, for showing all this interesting data and making the introduction on sleep duration. I think that Dr. Vgontzas convinced you that not sleeping enough or having poor sleep is not a good thing for your memory. Now, in my talk, I'm going to try to convince you that those who sleep long may have problems with their cognitive performance. So going back to a small, very short introduction, as Dr. Vgontzas already said, there is some studies based on subjective, meaning self-reported sleep, longitudinal studies that have come to mixed results. Meaning that some of them found that short sleep, long sleep, or both short and long sleep may be associated with worse cognitive function in future, where some others did not find such an association. But this is mostly subjective sleep, as I said, whereas studies on objective sleep, especially focusing in people with cognitive disorders, are very few. And here you can see that in patients with mild cognitive impairment, up to a point, very few studies have examined their association between objective sleep and cognitive performance. Some of them used polysomnography, which, as Dr. Vgontzas said, is the gold standard to measure sleep, but it's not easy because you need to do it either in a sleep lab or assess it through home PSGs, which are really a very hard thing to do, as we found out through this ELIREC study that he told you. So the studies up to now have been very small samples, and the findings were inconsistent and not specific. More studies have been made using actigraphy, which is a good way to measure objective sleep. And a big study by Spira et al., which is published in 2017, showed that there is a positive association between long sleep duration and worse cognitive function in a big sample of elderly people, which also included some percentage of MCI patients. So it was in the total, in a general population sample. Whereas another two studies, which were small in numbers, failed to find any associations between sleep duration and cognitive performance in patients with mild cognitive impairment. Now, when it comes to patients with dementia, here studies are even fewer, because you can imagine how hard it is to carry these studies in people who are demented, and the findings are completely conflicting. So there is one study that showed that people with short sleep duration, actually patients with dementia have a long sleep duration at night, and another one which showed exactly the opposite, meaning that demented people sleep shortly at night. Now, this difference between the studies can be explained because they used very different population to study. So in the first case, the study was in demented people who had rather early signs of the disease, while in this case, the study was in more severely demented patients, and in some cases they were also institutionalized. So here, Dr. Vgontzas went through the three phases of our Cretan cohort study, and I'm going to show you some findings based basically on the second phase and on the third phase, on the follow-up phase of the cohort. I have to say that in both stages, we had a very thorough neuropsychological and neuropsychiatric evaluation. And also in both stages, we had measures of objective sleep. In phase 2, we had actigraphy for 24 hours consecutive. And in the follow-up phase, we managed to have data for 8 days of actigraphy plus PSG that I'm not going to present today, though. This is the very first paper that was published in 2019 in the Journal of Sleep Research, which is the official journal of the European Sleep Association. And in this study, we tried to see if patients with mild cognitive impairment sleep longer or not, compared to healthy controls and compared to our dementia group. This was the first question. And the second question was if sleep duration is somehow associated with cognitive performance, especially focusing in mild cognitive impairment patients. So what we did find is that in the population we saw, which was over 100 patients, elderly patients with MCI have similar objective sleep duration with normal controls, while Alzheimer's disease patients slept longer for about 1 hour in total through the 24 hours, compared to the other two groups. However, although MCI patients did not, in general, their mean sleep was not higher compared to the healthy controls, we did find that among those MCI patients, those with multi-domain subtypes of the disease, those who slept long were performing worse in some critical non-memory cognitive domains. So this finding led to the conclusion that long sleep duration may be an early biologic marker of accelerated cognitive decline, especially in this group of patients. Another thing that we wanted to see was whether long sleep duration is in some way associated with genetics in patients with Alzheimer's disease. And it is well known in literature that the ApoE4 allele variant is associated with an increased risk of Alzheimer's disease and other dementias, and that people who do carry this gene have three times increased risk for Alzheimer's if they are heterozygotes for the allele, and 10 times if they are homozygotes. We have previously shown, as I already said, that people among cognitively non-impaired elderly and patients with cognitive impairment, objective long sleep duration is associated with worse cognitive performance. Furthermore, there have been a few studies in the past that have shown some association between subjective sleep quality and quantity and ApoE4. There were only 2 pilot studies, though, examining the objective sleep and the ApoE allele, and the findings were conflicting. So one showed that among healthy people, healthy elderly, carriers had shorter sleep duration and a higher awakening index, so more disturbed sleep. While the other one found, which was run in MCI patients, found no differences, both in sleep duration and sleep quality between carriers and non-carriers of the allele. So we looked in our data, and in 2021, with the help of Yannis Zaganas and the whole group, of course, we did publish this interesting paper where we showed that among patients with MCI and Alzheimer's disease, they all came from the second phase of the Cretan aging cohort study, those carriers of the E4 gene have longer both nighttime and 24 hours time sleep duration compared to the non-carriers, which meant that they slept longer during the night, both during the night and during the day, the naps. And based on that, we've concluded that objective sleep duration is a genetically driven preclinical marker associated with worse prognosis in elderly with cognitive impairment. Furthermore, we also wanted to see the interrelation between objective sleep, daytime sleepiness actually, measured by napping, the inflammation levels, and the cognitive performance in patients with dementia. And why did we want to see all this? Because it is well known that inflammatory markers are elevated in patients with cognitive impairments. But on the other hand, they are also associated with excessive daytime sleepiness, so being sleepy during the day. As I already said, people with dementia were found to sleep longer during the day, during the night and the day. So we examined the sleep, the daytime sleep, the naps of those who were diagnosed with dementia in our cohort, and we found that excessive daytime sleepiness is increased in patients with mild to moderate dementia compared to cognitively intact controls, meaning that those people who were diagnosed with dementia had longer and more frequent naps during the day compared to the healthy controls. Moreover, within patients with dementia, excessive daytime sleepiness was found to associate with worse cognitive performance and elevated inflammatory markers as measured by the IL-6 levels. So here we go again to the third phase of our study of the cohort. And here we included those who at 2013 to 15, at the second phase, were diagnosed with MCI or were healthy controls. We tried to find them and examine them again and see how their sleep and their cognitive status, diagnosis, and neuropsychological testing was 8 years after the initial evaluation. We ended up with 150 people. I have to say that that was a very hard thing to achieve because of the age and because of the COVID pandemic, which made visits to the houses stop at some period. So we had to wait to make sure we could see them again in person. And what we did is that we tried to compare cognitively deteriorated versus non-deteriorated participants. And the deterioration was compared between the baseline, so phase 2, and the third phase. And we used several statistical analysis models to see if long sleep could predict the way they had developed. And half of them were deteriorated 8 years later, while the rest were not. And what we did find is that long time in bed, not total sleep time, long time in bed, based on the initial evaluation, objective sleep, was a risk factor for deterioration. And as you can see here in this table, those who stayed longer in bed at baseline were almost 5 times more likely to deteriorate 8 years later when we followed them up. And this is the paper by Eleni Skurti. And here we also tried to check if baseline measurements of time in bed and total sleep time could predict neuropsych testing at follow-up. And we did actually find that 24-hour time in bed at baseline could predict the memory at follow-up, and as well as total sleep time in baseline evaluation could predict several memory indices at follow-up. And so we ended up saying that those people who sleep longer are more likely to have some deterioration in their cognition later on in their lives. And trying to understand and explain these findings, several underlying mechanisms could be suggested. So one is through the beta amyloid, meaning that from one side, accumulation of beta amyloid may lead to disturbed sleep and wakefulness cycle. On the other hand, if your sleep is deranged, the deposition is increased. Another mechanism may be through abnormal tau that is the earliest associated observed pathology related to sleep regulating regions of the brain. Another mechanism may be through elevation of inflammatory markers that we know that may be increased in people with cognitive problems. Other explanations may be through sleep apnea, genetics, melatonin, etc. So, in conclusion, what we did find is that elderly patients with MCI have similar objective sleep duration with normal controls, while AD patients sleep longer. However, within multi-domain subtypes of MCI, long sleep duration may be an early biologic marker of accelerated cognitive decline. Furthermore, ApoE allele is associated with objective long sleep duration in elderly with cognitive problems. In demented patients, the objective daytime sleepiness may be a biologic marker of the severity of the dementia. And finally, through longitudinal data, we may say that long time in bed and long sleep at baseline may predict deterioration of clinical cognitive status and memory deficits in non-demented elderly at follow-up. So sleeping long or sleeping short are bad for your memory. This is the message of our talk. And since there is no cure for dementia, as Dr. Vgontzas said, it is important to focus our efforts on prevention, identify people at risk, and the people who sleep longer or have bad sleep seem to be at risk of having issues with their memory in future. So one may suggest that multitask interventions focusing on diet, physical activity, cognitive training, regulation of blood pressure, obesity, etc., may help people to have a better course and delay cognitive problems. Another thought could be that treatment targeting inflammatory pathways may be helpful in people who are at risk for cognitive decline. And of course, one last finding is that what Dr. Vgotzas always says, that sedative antipsychotics in people with cognitive issues should be given with a lot of caution because it increases their sleep duration, and this may cause further deterioration of their cognition. On the other hand, people who do have insomnia, even if they are elderly, they can be helped with CBTI or trazodone, depending on the type of insomnia that Dr. Vgontzas explained to you before. And through this, they may be a prevention for them to face cognitive issues in future. So I'm going to say this in Greek. Ο Ιπποκράτης πριν από πολλά χρόνια είπε ότι τόσο ο ύπνος όσο και η αγρύπνια, αν ξεπερνούν το μέτρο, σημαίνουν ασθένεια. Εμείς, based on our finding, we may say ο πολύς ύπνος σημαίνει ασθένεια, είναι δείκτης δηλαδή ότι έχει ήδη ξεκινήσει μια διαδικασία έκπτωσης της μνήμης. Απ' την άλλη, ο λίγος ύπνος προκαλεί ασθένεια. Ευχαριστώ πολύ για την προσοχή σας. Longitudinal studies may investigate the role of other factors such as sleep apnea in these directions. And we're now open to questions.
Many thanks, Maria. Many thanks, Professor Vgotzas, for these excellent and very informative and very interesting talks. Let's move now to the discussion. Are there any questions from the audience? There are a few questions in the chat box, actually. I will begin with them and then we can move to further questions. The first question is for, I think, for Dr. Vgotzas, is insomnia defined only mainly on the basis of total sleep duration or also on subjective report of not being able to sleep enough? We cannot hear you, Professor Vgotzas.
I forgot. I said, that's a good question because there is an easy answer and a simple answer. No, insomnia is primarily defined on subjective report, as DSM-5, whatever says. Difficulty falling asleep, staying asleep, early morning awakening, next day, daytime impairment, fatigue, memory problems, and the like. So insomnia is not defined just on the sleep duration. You have to have a complaint. If you do not have a complaint and you say I sleep 6 hours, you're not an insomnia. You are a short sleeper. And there has been, I can talk about that for the next 5 minutes, but I don't want to dominate here the discussion. But we have been asked again and again, what about if someone sleeps short but does not have insomnia? Is there a problem? So I gave you the answer, yes. Insomnia is insomnia plus then the sleep duration, short sleep duration, the more severe one, normal sleep duration. It has also psychological problems and so forth. Normal sleep duration responds to psychological treatments, short sleep duration responds to medication. We say about trazodone, now they're talking about orexin agonists. The future is there, but that's the basic distinction. In fact, we've gotten a very large grant, multi-site grant now in the United States. So there is that question. Short sleep alone is a problem. The answer is yes, it's extremes. Actually, there was a British investigator, Jim Horn. British are smart people, but sometimes they're very arrogant. So he was saying, that 4 hours of sleep is enough. All the other, is like at your, your choice. Only we need 4 hours. That's not correct. I mean, we have done studies again and again, with George and other people, and we found in young people, without that, if they sleep less than 6 hours, they are sleepier, their concentration is impaired, all this, but also they have higher inflammation and so forth. So short sleep duration is not good beyond the point. As you know, of course, there is variability. Not all of us are, genetically, loaded to sleep 8 hours, because sometimes you will see, the American Medical Association, the American Academy of Sleep Medicine says you should sleep 7 to 8 hours. That's not correct. I may function very well with 6 hours, you may need 8 hours. Both of us are good. But if you tell me that you're sleeping 5 hours or you're sleeping 10 hours, then there is a problem.
And does the percentage of time in deep sleep play a role in a more efficient sleep?
No. Unfortunately, yes, when you analyze it, in a quantitative manner, or with period amplitude analysis or FFT, whatever, like quantitative analysis of the EEG waves, then we saw the difference of slow wave and so forth. But when you measure just, the visual scoring of sleep, what we call slow wave, it does not play a role as we would have expected. And just referred also to it was a long search from a pharmaceutical company, along with many sleep investigators, primarily from the United States. And they have found, what they used to call enhancers of delta sleep. Another way, to call slow waves is delta sleep because of the delta wave.
I have not posted.
All right.
Nikos?
Okay, so thank you both can you hear me well? Yeah, thank you both for this presentation. They help everybody because it's a very complex association. So one clarification mostly. So in the Cretan aging cohort, do you see both phenomena being there? Like we saw the associations between long sleep duration, we saw data on the multi-domain MCI, on the association with ApoE, but also we heard about the short sleep duration in people with insomnia. So in the same population, in the same subgroups, or in the same analysis, do you see both phenomena taking place, like increased risk in both the long, both on the long side and on the short side. So do you see these extremes happening at the same analysis in the same population in different subgroups?
I will take the lead and then Maria can speak more. Yes, we do. And that's, really it's a difficult concept, as I said, from the very beginning to dissect, I think MCI is any kind of disorder. It's a heterogeneous disorder. I mean, insomnia.
Recording stopped.
Can we go ahead? Oh, because
yes.
I mean, schizophrenia is not one thing. Your neurological disease, Nick, is not depression and insomnia. Now we claim it's a heterogeneous disorder. Okay, so I think the same thing. We start seeing, in terms of sleep, and maybe this may lead to a new phenotyping from clinical and physiological data within MCI, okay? Because, as Maria well said, there is that group that sleeps well, and maybe everyone is happy at home. Recently, I saw such a patient in the health center south of Heraklion in Mires, close to Matala, that the wife came and said, "Oh, I have seen him for memory complaints 2 years ago," and said, "Oh, doctor, my husband sleeps very well. And she thought that this is a good sign. But neuropsychological testing indicated that he is entered, early stages of dementia. And I would like to make that comment that Maria said, and I think we're arguing among themselves, we're debating, we're not arguing. I think the inflammation that we see in those long sleep duration is something, and the high cortisol is
recording in progress,
centrally driven and cannot be corrected with anti-inflammatory and so forth. While in the other group, the short sleep duration, in terms of prevention, I think it's important to diagnose it based both on subjective and objective criteria, as we already talked, and give any treatment that we talk that you think is good for insomnia. As I said, we believe pharmacological, biological treatments are good for the short sleep phenotype, psychological for the other one. Now, for the long sleep, as it is a biomarker, I think in terms to make an intervention, we will need, some really the progress that you, neurologists, neuroscientists, you are doing in terms of the mechanisms of dementia. There, like modifying sleep, I don't think it's going to help. Like you cannot say, because someone said, "Oh, let's tell them, to sleep less." I don't think it's going to work. It's going to make them work. We have not made that experiment. I don't know if it's also ethical for those people they sleep long to say, "Okay, let's put them, and sleep less." I think it will make them more tired and even more confused and even more delirious. That's my hypothesis. But it's, I don't think any ethical committee will allow you to do that, to deprive someone of sleep, maybe to shorten it. So that's the way I see it. Maria wants to say something also, I think.
Yeah, Nico, I think just focusing on the question you made, what we ended up is that being in, there seems to be this U-shape association. So sleeping shortly or sleeping too long predicts a worse course of your cognitive issues, of your cognitive performance, let's say, even if you're healthy at the time that you sleep long or shortly. So that's, it seems to be a marker. The etiology is different. Short sleep can, let's say, not cause, but seems to have a causal relation with insomnia, while a long sleep is an early predictor. So it's not good to sleep short or long. It's not a good sign, let's say.
If I can add here, Nick, is something I see another hand, but I'm allowed to make another comment, but relative to your question, because it's a critical question. The PennState cohort, which is about 1,750 people, one thing we noticed, with sleepiness was elevated. We're talking about the general random sample, it was in the 20s, 30s. We believe there because self-induced sleep deprivation, even depression, and then sleepiness was decreasing, 40s, 50s, 60s, 70s, and then after 70s, particularly 80s, 90s, we saw a huge increase of sleepiness. And based also some mortality data, we believe that this increase of sleepiness has to do with deteriorating health. And if we were able, it's an early sign that at some point death is coming. Like it's a sign of mortality.
I think we have still time for a question, for an additional question. Yanis, would you like to ask something?
Yes, thanks for the great presentation. Is there any knowledge in the literature about molecular mechanisms that could be triggered by sleep deprivation, either slow, short, or too much short, that will relate it with lower cognitive performance? Like you have less, you have atrophy on neurons, or do you have any idea why this is happening and what is any underlying biological mechanism?
I think in terms, if I can take here, the first step, I think, in terms of the insomnia, so sleep phenotype, I think the data are there. We have a sustained activation of the stress system, particularly cortisol. And as we know, there's been plenty of studies indicating that high cortisol is associated with reduced volume of hippocampus. So in that case, that's the mechanism. There may be multiple other mechanisms, but I think there is evidence about that, both, from neuroanatomic studies, from molecular studies, and so forth. So that's why finding ways, and we believe that that's why I said, the distinction between psychological and biological methods, finding ways that we can reduce successfully cortisol, a simple marker, but reliable, can be measured, is protective. As far as the long-term sleep, I think Maria already talked about inflammation and so forth, but I think there we know, and she talked about the ApoE. I don't know if she wants to make a comment, but just from my standpoint, I want to say that this is the secondary effects of something that is going on somewhere in the brain or the body that leads in demanding people to hypercortisolemia, to high inflammation. And that's why, although they have high cortisol, if you give them, let's say, a medication that will reduce the cortisol, as Maria said, like the sedative antipsychotics or any sedative, will make them worse. Because the hypercortisolemia in dementia is of different nature, of different etiology compared to the hypercortisolemia in the insomnia short sleep phenotype.
It is already 6:11. I would like to thank you all for the active participation in the discussion. And also I would like to thank our speakers for their interesting talks. Many thanks. Have a nice evening.
If I can say something,
Yes.
Panos, I would like to say, that thanks to Maria's efforts, this last part that they have given us, a lot of good data, and given that it was during the pandemic, she was able, to salvage the study. And so we're coming now with, some of them are published and more are coming. That will be in that direction we talked. I just want to recognize her for that and the entire team that was working with her.
I have to thank you for your attending the meeting today. Thank you, Panos, for chairing. Thank you, Dr. Vgontzas, for supervising all this big work. It has taken years and years of work, and all the group, of course, of people and researchers who participated in this effort. And we'll go on. Thank you.
Thank you very much
Thank
for
you
your participation.
Thank you to all.
Bye-bye.
Bye-bye.
Have a nice